welcome back to the Integrative Health Podcast with Dr. Jen. Today, we're going to be talking to Dr. Joseph Musto. He is president and clinical lab director of where I do a lot of my testing for MARCoNS, and we're going to be talking about that a lot today. Dr. Musto is the president and director of laboratory medicine, medical director, and founder. He was formerly medical director of diagnostic laboratory medicine for more than 20 years, and then he founded Microbiology DX. He's been involved in laboratory medicine and methods of developing for clinical testing for over 50 years with more than 20 publications and co-author of 7 issued patents. Dr. Musto earned a BSc in chemistry, an MSc in organic and physical chemistry, the equivalent of an MSc in biomedical science, and a doctorate in medicinal chemistry. Dr. Musto is a board certified clinical laboratory director and spent 10 years pre and post-doctorate training in clinical laboratory science before establishing his first clinical pathology laboratory in 1979. That's amazing, Dr. Musto. So nice to have you here. We've talked on the phone multiple times, and I would love for you to just tell the audience, why you're so passionate about clinical science and laboratory testing, and more about your background of how you got to where you are today.
Okay. Well, with regard to this whole biotoxin illness, an associate of mine called me back in June of 2011 and said there was this doctor in Maryland looking for a laboratory to do some special bacteriology testing. And I called him. His name, you may recognize, is Dr. Richie Shoemaker. And we had about a half an hour conversation. He asked me a lot of questions. And turns out over my career, I was a hands-on clinical scientist as well as textbook clinical scientist. So the end of the half-hour conversation, he says, okay, I'm going to have all the doctors who follow my protocol send these cultures to you. I said, fine. So we set that up. This was when I was the owner and director of diagnostic laboratory medicine. In 2015, I established Microbiology DX, and we continued testing for all of those clinicians, doctors, and so forth that followed Dr. Shoemaker's protocol. Over my career, I've been involved with endocrinology and toxicology, infertility testing, and I was very big on methods development. So this came along, and I really dug into it. And over the last 6 or 8 years, I've done a number of studies and written up reports on additional treatments for MARCoNS, and we'll get into MARCoNS and its definition and so forth. So I continue to do that, and for any of the clinicians, I have a very nice summary sheet of suggested nasal spray treatments, both compounded by compounding pharmacies, as well as products that are available on the internet, which are generally quite effective and considerably less expensive than the compounded product. But we'll get into that in a few more minutes. So that's pretty much my background. I actually studied a year and a half or so ago and passed the test that Dr. Shoemaker has created. And I became a CIRS proficiency partner diplomat, which made me feel good, gave me another credential. And so here I am. And if you'd like, we can start by kind of defining what chronic inflammatory response syndrome is. Okay.
Yeah, I think that would be great. And I think what's so important and why I wanted to have you on is because it's so important to test and not guess a lot of the times. And especially if you're kind of stuck in hitting roadblocks, it's really good to have these tests. It's so important moving forward because CIRS is such a chronic disease and it's really not recognized by many doctors. And
Yes.
one
Yes.
thing I love about having actual tests is, and I know, you know, as a clinical scientist and spending your life with this, then we can actually get the conventional doctors be like, look, we have actual evidence. This isn't false. This isn't snake oil. Because a lot of the times we get pushback. So I think that's why it's so important to have these tests available.
Uh-huh. Well, let me begin with a brief discussion about chronic inflammatory response syndrome.
Yes.
This is something, the name I think was started back in the early 2000s. Dr. Shoemaker coined that name. And what it is it's an illness that affects multiple systems and produces multiple symptoms. Now, he looked at it from his experience back in around 1997, where toxins that were produced by plantation growth in lakes and rivers, and these toxins were killing fish, and the fishermen were getting very sick. And he found that treating them with cholestyramine, which was at the time a cholesterol lowering drug, and what it did is pull the lipids out of the bile and reduce the cholesterol. And he found that the cholestyramine as a binder was very effective in pulling the toxins, these dead fish toxins, if you will, out of the individual system, and the symptoms disappeared. And I think that was his first publication in around 97, 98. In recent years, chronic inflammatory response syndrome has been expanded. It's a biotoxin illness. It can be primarily 80% of the people who develop this have exposure to water damaged buildings, whether it be in their home, their apartment, in a school. And the water damage produces mold, bacteria like actinomycetes, tick bites from babesia, from Borrelia, I should say. And it was found about 20 years ago, a patent was actually taken out on a biotoxin produced by Borrelia. So many different sources, but 80% of it comes from the water damaged building. And these toxins get into the circulation. They cause a significant upheaval of the innate immune system. And there's a certain genetic issue that 24% of the people have in the country, and they don't recognize these foreign toxins. So the immune system, the adaptive immune system, can produce antibodies to bind up these toxins and eliminate them. And that's where the cholestyramine comes in as an early part of the treatment. Now, MARCoNS is an important part of the Dr. Shoemaker protocol. It's step 3 in a 12-step protocol. And what are MARCoNS? MARCoNS is an acronym for multiple antibiotic resistant coag-negative staphylococcus. Okay. Now, I've spoken to patients who will bring a report to their primary care doctor. And at the top of the report, it says, staph coag negative, large amount, MARCoNS positive. And the primary care doctor will say, oh, staph coag negative, that's normal flora. Well, in this case, it's not normal flora. MARCoNS has been found not to be an infecting bacteria, but a colonizing bacteria. It generally doesn't show symptoms of rhinitis or sinusitis. It does show symptoms in some patients of brain fog, cognitive dysfunction. The reason for that is it was found back in 1998 by some scientists and physicians in Australia that certain coag-negative staph produced toxins, exotoxin A and B, and hemolysin, another toxin. In 2003, Dr. Shoemaker did a study with 512 patients to show the significance of coag-negative staph in patients who had what was called at the time chronic biotoxin associated illness, which became chronic inflammatory response syndrome. And these patients had low MSH from these toxins circulating in their system. Well, where MARCoNS comes into play, that he showed in this study in 2003, MARCoNS, the exotoxins they produce, also cause further degradation of MSH. Now, MSH is an extremely important hormone in biotoxin illness. It affects the immune system and it affects the endocrine system. So there is significant disruption caused by the inflammation that the toxins produce. And we see an increase in cytokines. When the MSH is reduced, it leads to cytokine production, which causes a whole host of symptoms. Now, Dr. Shoemaker, a number of years ago, took 37 symptoms associated with biotoxin illness. He divided them statistically into 13 clusters. He found if a patient had one symptom in each of 8 of the 13 clusters, the probability of biotoxin illness was 92%. Then he added to that a test, a visual test that can be taken on the internet or with the proper device in a physician's office called visual contrast sensitivity. Visual contrast sensitivity, if the patient fails that test and has one symptom in each of 8 of the 13 clusters, the probability of biotoxin illness, chronic inflammatory response syndrome, is 98.8%. So it's extremely diagnostic. It hasn't cost the patient more than $15 for the test. And the percentage is so high that then would be confirmed with a series of blood tests, including the genetic test, the HLA-DRDQ, which would show one of about 15 different haplotypes that are associated with biotoxin illness. So I think that pretty much shows CIRS and how MARCoNS fits into the whole diagnostic picture. Now, at Microbiology DX, we do nasal cultures for MARCoNS. When we do the culture, we send the kits out with the swabs and the preservative and so forth. When we get the swab back, we plant it on several different media and we make it a general culture. So it's not just MARCoNS. Whatever bacteria grow out, we report. And we decided to do that back in 2015 because you're the one, as a physician, face to face with the patient. We don't know what their symptoms are. Now, if they have symptoms aside from chronic inflammatory response syndrome, they may have symptoms of a sinus infection, and by reporting a complete culture out can be helpful to you as a physician. So I was surprised as we did this. We see enteric organisms, very common. E. coli, Klebsiella, Enterobacter, Proteus, for example. We see non-enterics like Pseudomonas, and it gives you a complete picture. We'll report that out with MARCoNS and work up these other organisms as we see them. Now, we offer a fungal culture as well. And again, the reason we offer that is the patient could have sinus symptoms of a problem, of an infection. And if the doctor thinks that this could be a sinus issue, then he or she can order both the bacterial culture for MARCoNS and other bacteria and the fungal culture to get a complete picture. We offer a biofilm test. Dr. Shoemaker contacted me back in about 2016, and he said, you know, you should develop a biofilm test for MARCoNS. So I searched the literature and developed a biofilm test. And based on the study that Dr. Shoemaker did back in 2003, looking at coag-negative staph and reduction in MSH, we found that if the staph coag-negative MARCoNS positive showed methicillin resistant, it was much more difficult to eradicate. So in a suggested treatment listing that I send out to doctors, I indicate that if there's methicillin resistance for the MARCoNS, it would probably be efficacious to extend the nasal spray by 2 to 3 weeks. With regard to the biofilm, I also suggest that if the biofilm is moderate to strong, that they also add 2 to 3 weeks to the typical nasal spray treatment.
So someone's listening out there and they're like, well, how does this even happen, right? How do they get these weird bugs up their nose? What would you tell them?
One is very basic, and that's hygiene. If people are not washing their hands multiple times a day, when you touch a doorknob, who knows who touched that doorknob before you? And if you run your fingers past your nose, you could pick that up. One of the first questions I'll ask a doctor is, does the patient have a dog or a cat? Dr. Shoemaker found out several years ago that dogs can carry the MARCoNS. And I was at a meeting talking with a number of doctors, and the question came up about dogs carrying MARCoNS. And one of the doctors asked me if I ever did any tests on cats. And I said, no. Well, there were 2 doctors there, and they each had 5 cats. And they sent me 10 cultures on their cats. I think 8 out of the 10 were positive for MARCoNS. So we now know that animals can pass that on. The other part related to animals, especially dogs, and you know, people love their dogs, and the dogs lick their face, and you don't know where the dog's tongue was 5 minutes earlier. So that's another source. And these bacteria are ubiquitous. They're everywhere. And if you're out in a public bathroom and you just touch a doorknob, God only knows what's on that doorknob. So it's common to see these. Okay.
Yeah, especially kids too. You know, they're always picking their noses, touching things. Yeah. So it's just that environment though. It's dark, it's moist. Like
Yeah.
bacteria, especially fungus, love it, right?
Yes, yes. Um, I'd like to mention a couple of points with regard to treatment. But before I get to that, I want to talk about Staph aureus and MRSA. We see quite a few cultures, nasal cultures, that are positive for Staph aureus. Some are positive for MRSA. Now, it turns out that the literature indicates that about 25% of the population carries Staph aureus in their nasal passage. They don't know they have it unless they have a reason to have a culture. You know,
Oh, yeah,
hospitals.
absolutely. I can
Yeah,
believe that. Well, I always thought that like so this is very off topic, not really, but my
sure.
kids would get like a little bit of eczema patches here, but it really wasn't. It went away if I treated them with an antibacterial agent here,
Ah,
specifically mupirocin. And
yeah.
it's interesting because I trained I residency medical school, so I for sure was colonized with MRSA. Just I was just in it, and most nurses and doctors are, I bet, and I think I passed that on to my kiddos.
Oh, yeah.
So I always felt bad about that.
Well, we see it very, very often. I had seen something in the literature that indicated that coag-negative staph doesn't grow in the presence of Staph aureus or MRSA. And it turns out that Staph aureus or MRSA produce some toxins that kill off Staph coag-negative. Now, there are about 13 common strains of Staph coag-negative, and one or two of the strains are capable of being resistant enough to these toxins. So about 1% of the time, we will see a report. I review each report every day. About 1% of the time, you'll see Staph aureus or MRSA with MARCoNS.
Hmm.
I reviewed about 500 plus reports that were positive for Staph aureus or MRSA to see how many of those had MARCoNS. That's where I got the 1% from. And the literature says that it kills coag-negative staph. So we did some experiments because we have these organisms available to us where we inoculated a broth with both Staph coag-negative and Staph aureus. The next day it grew out at 37 degrees. We then planted it on an agar, and the only thing that grew out was the Staph aureus. So that added to the support that Staph aureus kills off. Now, if the patient's been diagnosed with CIRS, then the question comes up, should the patient be treated to eliminate the Staph aureus or the MRSA? And I know some doctors will not treat the patient with Staph aureus because it prevents the MARCoNS from growing.
Interesting.
Yeah, most of the nasal sprays, I'll talk about those in a few minutes, would be considered broad spectrum antimicrobials. And I use the term antimicrobial rather than antibacterial, because when you talk about antibacterial, you're talking about drugs. And here, these are not drugs, but they're able to kill off these various organisms. One point that I'd like to make in terms of treating patients with MARCoNS, it used to be thought that use the appropriate nasal spray, for example, the BEG spray. And I can talk a little about that in a minute. And it may be 4 weeks or 6 weeks, 2 sprays each nostril 3 times a day. And then the clinician will say to the patient, well, I'd like you to come back in a week or 2 and we'll do a reculture. Okay. And the patient comes back and they have positive MARCoNS when they get recultured. This goes back 4 or 5 years ago. The doctors were thinking that the beg spray was becoming resistant.
Mm.
Well, it had been used for a good 10, 15 years, and it might have been developing resistance. In a conversation with Dr. Shoemaker about two and a half years ago, with a follow-up with an email for confirmation, he said the patient with low MSH, within 1 to 2 weeks, is going to recontract MARCoNS. So the best time to do a reculture is a week before they're going to finish their nasal spray. Whether they're on the nasal spray for 6 weeks or 10 weeks, whatever that is, a week before they're going to finish, do a reculture. That will indicate that the nasal spray was effective. Patient stays on the nasal spray until the report comes back. The report usually comes back within 1 week. Hopefully, the report shows the spray eradicated the MARCoNS. They should now go on to a maintenance dose. Now, this is based on Dr. Shoemaker's protocol of the 12 steps. And the last step in his protocol is vasoactive intestinal peptide, VIP, nasal spray. It turns out that there are 4 requirements for the patient to be able to get that nasal spray. One is they have to be out of a moldy environment. 2 is they have to pass the VCS test. 3, they have to be negative for MARCoNS. And 4, they have to have blood tests for lipase and GGTP for the liver before they get the administration of the VIP. So that's where the importance of a maintenance spray comes into play. Now, he recommended 0.25% EDTA, 1 spray each nostril twice a day. I have found there's a nasal spray that I have some favor, if you will. It's on the internet. It's called ACS nasal spray. It's 50 parts per million. You can buy 3 1-ounce bottles for about $25 or $30. I suggest, and it's up to the doctor to make the decision, that they use that as a maintenance spray.
And how long, when you say maintenance, I mean, how long does that mean?
Well, it could be 3 to 6 months. That it may take that long for the patient to get through the entire protocol. You know,
Yeah.
with the binders and then the blood test, monitoring the patient, TGF beta, MMP9, C4A, and so forth.
Yeah. And, you know, a lot of, because I have practitioners that listen to my podcast too. Some of us are more doing like a hybrid, right? Like we're using a little bit of Shoemakers, but maybe not all, because sometimes it's hard to get that blood work. It's actually impossible. And then insurance doesn't cover it. It's like $1,200, right? So some, and a lot of people, they can't pay for cholestyramine. It's expensive, or they can't tolerate it. So some of us are using a little hybrid, but I do know that the nasal part, sometimes I will have patients that their mold is treated, but we're stuck here on this nasal part, and or that's their only symptoms they have. And to be fair, you know, and going with Dr. Shoemaker, if you don't treat that, and if there's MARCoNS present and you don't treat them, you're just going to keep that inflammatory response going on.
Yes.
Now, I think I talked to you about this on the phone before, but I love KPV, which is a peptide that is part of MSH. And I feel like the patients that I've put that in, their nasal symptoms, you know, their cultures like have gotten better a little bit faster. I mean, what are your thoughts on that? Because for people listening out there, it's kind of like this ridiculous like cycle of you have low MSH, alpha MSH. So then you're allowing the MARCoNS to thrive, but then you can't get rid of the MARCoNS like you just said because there's low MSH. So it's this kind of like circle. So,
well, the KPV, I did some reading up on that earlier this year, and it turns out that NSH is antibacterial and KPV is antibacterial. So I would say, just digress, that antibacterial, I saw some studies and it was effective against Staph aureus and it was effective against Candida. Okay. So I'm making the assumption if it's effective against Staph aureus, it would be effective against Staph coag negative. So I think that's why you're getting such a good response with the KPV.
Yeah, it's been really helpful. So we were talking about the maintenance dose, sorry.
Yeah, sure.
And so they're on the maintenance dose. When would you recommend retesting then? So they're off the bag or they're off, you know, whatever they're on, and then they're on the maintenance. And what about symptoms too? Because sometimes it takes a while for the symptoms. And I've had patients say anything from just a stuffy nose, they're not sleeping well, they feel congested, to like a deep brain headache that really nothing has worked until we eradicated, you know, bacteria and candida in the nose. And also, like you said, brain fog, like blurry vision, like a coat over their eyes, like very, very interesting symptoms. And we've ruled out things like brain tumors and vision checks. Yeah. And that's the thing. It's these people that come to me, and then I'm sure that are getting testing with you. I mean, they've been through the conventional medicine gamut. Like they had every scan, and you want to rule things out. You can't just say blame everything on mold. You have to do your due diligence and rule things out. But so many people just never get better. And that's when we need these specialty testings and to really dive into the science of why they're still feeling like crap, why they're still getting brain fog, this inflammation.
Well, I think part of that could be if the MARCoNS are present, and when we send a report out, most of the reports will show a large amount. Okay, we categorize it as a small amount, a moderate amount, a large amount. Now, it's not like a urine culture where a laboratory actually measures the volume of urine put on the plate. So we give a colony count of greater than 100,000 or a number like that. Here we're getting a swab, so it's not quantitative, if you will. But I think the toxins that the MARCoNS are producing can cause the symptoms that you just described. And eradicating the MARCoNS to eliminate those symptoms, in addition to the negative effect it has on MSH, I think that both of those are very important. And I've spoken to a number of clinicians who have been doing work in the field of CIRS for 10, 12 years. And they tell me if the patient doesn't eradicate the MARCoNS, they never get completely better. So I think from what you just described, could be a patient like that. And, I could see where the KPV would be beneficial. You know, if the MSH is normal or close to normal, right, here's just a little piece of information. In this study that Dr. Shoemaker did back in 2003, showing how the MSH was suppressed in these chronic fatigue patients and what the effect was on the coag negative staph. I lost my train of thought there for a second.
Yeah, so let's talk about, while you go back on that, VIP spray. So
Yes.
one, I don't use it a lot in my practice because I feel like the patients that have come to me early on in my practice from other providers that were on VIP, they say they can't get off of it. And they're like, if I stop it, I feel awful. So I've just tried other things. I'm not one to jump on that quick to prescribe. So what have you seen? And then part of me is thinking, well, maybe they didn't do good on the VIP and they feel like they can't come off it because they went on it before their MARCoNS was eradicated.
Well, I've spoken to some patients who have been on colloidal silver, either what I mentioned earlier or a compounded version of that with EDTA. And it turns out that patients take it upon themselves to do various treatments like rinsing with saline. Well, if you rinse with saline and you're on silver, and you don't separate the time between the silver and the saline, you inactivate the silver. It produces silver chloride. And I've spoken to a few patients who said, I was on VIP for several months and it had no effect on me. And then I asked them about silver and saline, and that's probably the reason it didn't work. There's got to be other reasons. I think the key point is doing whatever's necessary to get the MSH up. Oh, and the point I was going to make about Dr. Shoemaker's study. In that study, the MSH reference range that he used had a lower limit of 26. In recent years, the lower limit has been 35. And just a point of importance here, I know that LabCorp did a reevaluation of their normal range, and they print on their report 0 to 40. Okay. I tell as many doctors as I can that Dr. Shoemaker says that's incorrect. It still has to be 35. They didn't change the method. They just did statistical analysis on what they called normal patients who probably weren't normal.
Mm-hmm.
So I've spoken to clinicians who tell me if they get a patient who has an MSH less than 8 or 10, and after eradicating MARCoNS and treating 3-4 months with a binder, that their MSH will go up to 22, 24, 25, and the patient feels significantly improved with their symptoms. So, and I know that some of the clinicians don't use the VIP. They're able to take the patient through with the binder, elimination of MARCoNS, and working to treat the cytokines to get them down into the normal range. And all of that contributes to making the patient feel better. And the key point is that VCS test seems to be extremely important in the Shoemaker protocol. Before they start the VIP, they have to pass it.
Mm. And I don't think that's done all the time.
It's an inexpensive test, and it's
right.
And I didn't mention this, but I'm sure you know this, that what the VCS test is showing is whether or not the patient has toxins, biotoxins, neurotoxins circulating in their system. That's why they fail the test. So it's a very important test. And the good thing is it's about as inexpensive as you can be. Of all the tests that are done, that's the least expensive test. So
yeah.
Very important.
And for those listening, it's a visual contrast test that you take online.
Yes.
And yeah, and it's sometimes if a patient doesn't, if we don't know if the mold's in the house or not, sometimes I'll be like, have a family member take that or your spouse, and we'll see if they fail. If they fail, you need to get a good remediator in there, an inspector. I think that's really such a hard part with mold and mold illness is living in it and in the VOCs and just not knowing where it's at, maybe not having good inspectors, especially if you live in certain areas of the country. It's very challenging and it could get really expensive, but if you're feeling like crap, there's a reason for that. And yeah, and having MARCoNS, having mold, and being exposed to it, it's going to cause so many health problems down the line. It's just something you have to take care of. Now,
Well,
I do want to say one more time that what you said about the silver,
oh, okay.
because I think it was like over a year ago or something, you told me that. And I was like, no one has talked about that. I had not heard that before. So silver nose spray, do not use around nasal saline spray. Use them separate. And it's just so fascinating because it's just, I don't think a lot of people know that. Would you say? I feel like it should say
Yeah,
it on the silver bottle.
yeah, I agree with you. There's a product. I've done a number of studies on all these different products over the last 7 or 8 years. There's a product, again, over the counter, if you will, Xlear,
Yes.
Xear, and that's grapefruit seed extract and xylitol. And that was quite effective in eradicating MARCoNS.
Oh,
Other,
good. I like Xclear. I recommend it sometimes, to acquaintances if they just ask about stuff, or if people ask me on Instagram, they're like, what's a good nasal spray for prevention? And even with viruses, because they have it at like, the conventional drugstores. So it's good.
yeah, the Xlear I found to be effective against gram-positive, gram-negative mold and yeast. Now, the xylitol, the grapefruit seed extract, is antimicrobial. Well, the xylitol is as well, and that's also used to break through biofilm. And I know some clinicians will have the patient use the Xlear in the morning and at bedtime, 2 sprays each nostril. And then during the day, use the silver if they can fit in 3 doses, 2 sprays each nostril 3 times a day. I recommend that there be a 2.5 or 3 hour time period between the silver and anything with saline. Xlear's base is saline. Okay. There's another product that I just recently finished doing a study on. Again, it's something on the internet. It's called Hyla Mist, Hyllamist, and it's grapefruit seed extract and hyaluronic acid, which is supposed to be very soothing to the mucous membranes.
Mm-hmm.
And it has antibacterial activity as well. And I found it to be effective against gram-positive, gram-negative mold. So that's another, I think it's about $8 for a 2-ounce bottle. And I think the Xlear is around the same, $8 or $10. And
what do you think of the iodine-based nasal sprays?
Iodine, I had done some experiments several years ago with that. I think they're quite adequate in killing all MARCoNS. It depends upon how concentrated they are and if there's no nasal irritation.
Right. Yeah, and that could be a problem because I've had patients before where they have gotten bleeding, because they're just so dry and irritated.
Well, let me mention something about that. The beg spray. Dr. Shoemaker worked with a pharmacy here in Massachusetts called Hopkinton Drug. Hopkinton, about 1.5 years ago, was sold to a pharmacy in Texas, and all of the formulations from Hopkinton went there. But I've spoken to doctors across the country, and for some reason, the concentration of gentamicin, which was in the original preparation maybe 20 years ago or 18 years ago, the gentamicin was 0.025%. I spoke to a doctor in Texas about 3 years ago. She was treating herself for CIRS, and she told me she had to stop using the beg spray because after 4 days, she had a nosebleed.
Mm-hmm.
They asked her what the concentration of the gentamicin was, something like 2%, which is outrageous. I don't know where those numbers came from, but I can say that I haven't spoken to anybody who had a problem with the 0.025%. And I think it's still an effective alternative to treat MARCoNS.
And then another method I know we have done with a patient before is just hydrogen peroxide nebulized. Can you talk a little bit about that?
Yeah, I did some experiments with that 3 or 4 years ago, and I found that it was effective at about 0.5%. And I've recommended to some clinicians the patient can purchase a 3% food grade hydrogen peroxide. And the reason for the food grade is it doesn't have any preservatives. What we buy in the local pharmacy will have preservatives, and it's best to keep away from that. The problem with the hydrogen peroxide is you can't get it from the pharmacy. They don't make it up. The patient has to make it up themselves. So I suggest that they start with a 1% solution, and they can either use it in a nasal spray bottle. If they have one, they can wash out and put the 1%. If they find that it's irritating, they can make up 0.75%. And I have a little scale, a little cheat sheet, if you will, that if you take 1 shot glass of 3% hydrogen peroxide and several shot glasses of water or saline, you can make up these different dilutions. And I suggest that the amount that you make up, to use it for maybe 4 or 5 weeks, and then discard it and make up a new batch, because it may deteriorate in concentration. But hydrogen peroxide is very effective. I found 0.5 was cutoff. You should stay at 0.5 or higher.
And that would, and I mean, I guess with all the MARCoNS, like, why does some work for some people, some for others? Just because we're all different, and it's just kind of trial and error, right? I mean, nothing's cookie cutter when it comes to this, right?
If you look at the susceptibility on the lab report, you'll see MARCoNS positive, and then you see a paragraph that explains MARCoNS and MSH and so forth. If you look at the susceptibility, if you got a lot of R's, there's 14 or 15 drugs on that list. And I've seen 10 or 11 R's on some of the patients, and I know that that's going to be more difficult. So you may want to use a longer duration for the treatment. Generally, it's about 6 weeks. And if you have a lot of resistances, I would extend that for 3 or 4 or 5 weeks. I want to make mention of something about silver. There's 2 products that are commonly used. One is called Argentin 23, which is 23 parts per million. And the other is this ACS nasal spray, which is 50 parts per million. I did some looking into toxicity of ionic silver. These are products that have silver with a +1 charge on it. If you take a tube of either one of those and you add some saline to it, it's going to get cloudy. It's producing silver chloride. I looked into toxicity. Now, with the ACS nasal spray, 50 parts per million, if that's used for 6 weeks, the total amount of silver the person consumes is 2.52 milligrams of silver. To reach toxicity, This would be in a 70-kilogram individual. You would have to do 1,388 6-week cycles of the 50 parts per million to reach toxicity. So you can see it's going to take years to reach 1,300 cycles.
Right.
So even, I'd like to talk a little bit about nebulizing, because these products could be nebulized. And I think we spoke on the phone about the NasoNeb. Okay. I suggest to the doctors, if they're going to have the patient do that, that they get a 1 ml syringe. And with the NasoNeb, which is specific to go up into the nasal passage.
Right.
Okay. If you put 1 ml to the left side, put another ml to the right side. Now you can even use more if you had to. That should be very effective, and that would get into the sinuses, because the nasal spray, even if the patient holds their nostril and does the other nostril with the spray so as to get it deeper, I don't think it's going to get deep enough into the sinuses, but the nebulizing definitely will. And I know the standard type nebulizer with the mask that goes over the nose and the mouth, that's also very beneficial, and that'll get into the whole respiratory system.
And that could be a reason why maybe people aren't eradicating this.
Well, you know, about 4 years or so ago, Dr. Shoemaker had worked with a biological dentist and found that patients who've had extractions or who have had cavitations can be harboring MARCoNS. And those patients will never be able to completely get rid of MARCoNS in the nasal passage. So that's just something else to be aware of. What's the dental status of the patient? One other thing, silvers, by the way. I didn't do this with the Argentin, but I did it with the ACS product. The silver breaks through the biofilm and kills the bacteria. And I did experiments to prove this. So either one of those silver products could be used. And I would suggest, if the Argentin is going to be used, to do an extra spray. So 2 sprays each nostril, I would say 4 times a day. Whereas with the ACS being 50 parts per million, they could do that 3 times a day. Now there's other products, and these can be purchased from PD Labs. That's the lab that purchased the Hopkinton drug. There's a product that's based on witch hazel, and I did studies on that, and it was quite effective against MARCoNS and other bacteria, mold and yeast. It's a combination. It's called Wizovax with 0.5%, 2.5%, and 0.25% EDTA. Beg spray is still available. There's another nasal spray I did a study on, which is stronger than the Xlear and the Hylamist. It's grapefruit seed extract. It's at 0.5% with 0.5% EDTA. So that's another one that is a broad spectrum antimicrobial. So there's quite a few choices that doctors can use. Prescription drugs, or I should say prescription formulations, are usually about $120, $140, including shipping. Whereas the products that are available on the internet, like the Hylamist, the Argentin, the ACS, the Xlear, they're all much, much cheaper, much less.
And it just takes time with all of these methods. It takes time. And I think everyone wants like a quick fix for everything. And it's like, it takes time to change your biome of your nose. Like,
Yeah.
well, thank you, Dr. so much for being here, Dr. Musto. And or Musto, sorry. See, I said it wrong. We were even joking about how his name is Must, like musty, like mold. So it was so funny. But thank you so much for being here and just like going into detail about these things, because not a lot of people do. And this will also be a good podcast or reference for my patients, because sometimes we don't have an hour to talk about the MARCoNS.
Now,
So yeah.
all of the treatments that I mentioned, if anybody is interested, I have a 2-page sheet that goes over all of these. I'd be glad to send it out to anybody who requests it.
Okay. Is it fine if I leave your email in the podcast
Sure.
notes?
Yeah.
Okay,
Absolutely.
awesome. Yeah, and it's great. And if you're a clinician ordering this test, it's so nice. You can always call. He's always there to talk and to go over the labs. And I've had to do this with a few tricky cases. And you're always doing new research, new products out there, which is great. It's just so helpful. So thank you so much for being here. And I'm going to drop your email. What is the website of your lab company to share?
It would be microbiologydx.com.
Awesome. And I will put that in the notes too. Thank you so much. Hopefully there was like a tornado watch. That's why I had to put in my earphone. Well, watch. It's not a warning. Warnings are worse. But it was like storming, and I was like, I couldn't hear you for like 5 minutes there while I was finding my earphones. So I'll have to go back and listen.
Thank you for inviting me.
Thank you so much for being here.
Very well.